Hello, everyone, and welcome to week 6. Hopefully, you are starting to gain a bit more confidence in your ability to understand the respective categories of disorders. As I have sort of noted for you throughout, I strongly encourage that you find time to connect with other students in the class so that you have the benefit of role playing the various conditions in the DSM. It really is going to help to have a fellow student offer to you a story like a client would give about what brings them into therapy, drawing from the diagnostic categories in the DSM. And then for you to attempt to determine through your questions and listening, perhaps referring back to the intake template, the mental status exam that I offered to you early on, that you attempt to determine through your questions what you are seeing and what diagnosis is being presented. Or you may wish to locate, of course, at your cost, the movie Call Me Crazy, to use those character stories to help you find the person in the DSM. The movie does a great job, in my opinion, of depicting the 5 mental health issues included. And just for clarification, this is a paid movie and not one that I'm going to provide for you. So I do reference videos. Some of those you will find in just the complete slides. You should be able to play them there. Or if you are thinking about the videos um, from Call Me Crazy, then you will need to purchase that. Okay. The last thing that I want to say as we begin week 6, you've had a few quizzes up to this point. I strongly encourage that even though you have the hour to complete the video and it is open book for you to do the quizzes, excuse me, the quizzes, not the videos, I would really encourage that you attempt to do the videos without your materials. This is going to be imperative because when you are sitting in the therapy room with a client, you're not going to be thumbing through the DSM. So you have an entire hour. If you were in class with me, you would probably have 20, maybe 30 minutes to complete the quiz. So you are online, you have a full hour. Perhaps take the first half an hour, just do it without the book. And if you want to go back and check it, certainly do that. But that would be my encouragement. Okay? So now let's get started with this week's diagnostic categories. This week we are focusing on sexual dysfunction, paraphilic disorders, and gender disorders. Now, each of these are separate groupings of conditions and do not share common features, even though we're talking about them together. Sexual dysfunction is separate from paraphilic disorders and gender disorders. Let's start with understanding sexual behavior and expression from the vantage point of the DSM. Caveat here, it's not unusual once students start to learn about these conditions to have opinions about the issues themselves and sometimes opinions about the person who presents with the issue. Here is where I will draw attention back to our early lessons. Our job as clinicians is to offer assistance and hope and to walk alongside. Ours is not to judge. Okay? Remember that the therapy space belongs to the client and is open to the issues that the client presents and is open to how the client feels about the issues. We should not, with our introduction, disrupt that dynamic negatively, okay? So self-observation is going to be really useful, particularly as paraphilic and gender-related issues are learned, okay? So be mindful of self, free the space for the client's issues, the client's perspectives, and none of your judgment, okay? So enough of that. In this slide, I have provided three columns for you to offer general understanding of the issues. Okay, so for instance, when the DSM is referencing sexual dysfunction, it's related to the difficulty in performing the act of sex in the way of arousal and orgasm achievement, which we realize is a potential problematic issue for couples. And when we're talking about paraphilic disorders, what are those? These are conditions where sexual arousal is achieved. However, it's achieved to inappropriate context, meaning inappropriate individuals or objects. So, sexual dysfunction is the difficulty having sex or being aroused. Paraphilic disorders, there isn't a sexual problem, meaning dysfunction, but there is sexual arousal inappropriately. So as you can hear, the issues are not the same for paraphilic disorders. They're not the same as sexual dysfunction, which entails performance or lack thereof. Finally, gender dysphoria is related to sadness, dysphoria, right? It's the sadness or dysphoria that arises from the incongruence between one's assigned gender at birth and how the person feels psychologically about their gender or what they believe their gender should be. So it hits at the heart of that dissatisfaction. It is not considered to be sexually deviant, nor is it a matter of sexual dysfunction or sexual inappropriateness. In fact, it's really not about sex at all, but about gender. Okay, so I'm going to repeat that with gender dysphoria, it's around the dissatisfaction and the sadness in the incongruence in the person's assigned gender at birth and how they feel from a gender perspective. Okay, so I hope that's clear. With those explanations, we're going to dive into the sexual dysfunction category of disorders. Sexual dysfunction is measured in 4 ways. We're looking at desire, arousal, orgasm, and pain. The first 3 of those, your desire, your arousal, your orgasm, are shared by both males and females, but the pain category is specific to women. Okay, so what is desire? It is little to no interest in any type of sexual activity. It's the lack or minimal interest as measured by activity, although activity could be present without desire. Okay, so hopefully that makes sense. Desire could be the lack of or minimal interest in having sex. Okay, however, a person could be engaging in the activity but still be absent of desire. So you want to ask about both because you could have a partner who's actively engaged but really minimal interest. Usually desire is demonstrated as having no fantasies. The DSM also mentions and or no masturbation, suggesting that the DSM considers masturbation to be neurotypical behavior. When we're thinking about desire, this is more common for women, and as it regards men, there is an increase in issues around desire as men age. So what is arousal? It is considered to be the absence of fantasy or desire. okay? Arousal can be more distressing, of course, for men, or maybe not of course, but arousal can be more distressing for men than for women because the act can't be performed for a man. Intercourse can't be performed for a man without it, or without arousal, although women can compensate with lubricants, right? So that helps to explain some why it may be more discomforting for men. Arousal is going to be present for nearly 60% of men once they are at the age of 60 and older. Okay, so we're looking at here when we're talking about arousal, we are meaning lubrication for women, which is usually denoted as arousal, and then erectile dysfunction for men. Orgasm is denoted as the inability to reach climax as a result of some sort of sexual activity or issues with controlling the orgasm. This issue tends to be more common with women than with men, more so for unmarried women. But when it presents in men, it's usually around a control issue, like an early ejaculation or an early climax. And so the inability to control that becomes problematic. So these first three, desire, arousal, orgasm, are present in both men and women. So we're going to really now go into the sexual dysfunction in that we have an understanding of desire, arousal, orgasm, and then I'll talk about pain. But sexual dysfunction is differentially assessed for men and women naturally because of anatomy. So importantly here, it's worth noting that there is an expectation that sexual interest is present, should be present, and that the absence of sexual interest or desire is considered to be atypical in the DSM. For males, the lack of desire would be referenced as male hypoactive sexual disorder, and for females as sexual interest arousal disorder. Okay, so you see I've created the 4 categories on the left side, and then I've separated the dysfunction into the 2 categories by gender. So when we're looking at desire, again, for males, it's going to be termed male hypoactive sexual disorder. For females, sexual interest arousal disorder. Let's say, however, that there is desire but an inability to demonstrate arousal for sexual activity, then an arousal disorder is given, and it's going to be erectile dysfunction for men, and then again the same, female sexual interest arousal disorder. So we can see how if we were to give female sexual interest arousal disorder, we would indicate we're referencing desire. If we are giving a female sexual interest arousal disorder, we would denote that we're referencing arousal, okay? But they share the same diagnostic label. For orgasm issues, men are indicated as having issues with ejaculation, either too early or it's extensively prolonged, without consensus really as to what constitutes a reasonable time frame for either of these. So this really becomes specific to the male and getting that information, so there's no real time frame for this. But if it's an orgasm issue for a male, it's going to be related to the timing of the ejaculation. And then for females, this disorder would be female orgasmic disorder. And it's situated around the absence of orgasm though it's worth noting here that women tend to acquire orgasm as they age, as they become differently stimulated, and as they learn their bodies. So when we're thinking about giving this disorder for women in terms of orgasm, we really want to get information. We want to sort of probe and understand to make sure that we're not prematurely giving this disorder when maybe there isn't enough understanding about the woman's female body, her understanding about her body to know how to reach orgasm. Finally, the matter of pain is situated with women in the form of genital pelvic pain and penetration disorder. Now, a number of reasons may contribute to this. However, the DSM does not, to my knowledge, link this disorder to something like perimenopausal issues, which results in vaginal dryness and those sort of things that leads to the pain. In that instance, that's really going to be a situation related to a medical condition and not pain related to the woman's anatomy in some other way. So that would mean that we would need to separate and rule out, right? Have them see someone to rule out medical conditions from what's being referenced here, okay? Things like pain, anxiety, tension with the activity, problems with penetration, that's what we're talking about. And there could be, as you can see, a psychological component to this, as well as an anatomy component to the pain disorder for women. Now, in this particular slide, we're talking about assessment, and the assessment reflects desire, arousal, and orgasm with dysfunction occurring in one of those domains. Now, when we're giving this diagnosis, right, or pain, when we're giving this diagnosis, it generally has to have a 6-month duration, and that's across all of them. The desire, the arousal, the pain, the orgasm issue has to be present for at least 6 months before we're giving this diagnosis. The specifiers here are going to be lifelong, meaning this was chronic. It's something that's chronic but was present throughout the person's sexual life, okay? As opposed to acquired, meaning there was some normal period of sexual activity without desire, arousal, pain, orgasm issues, and then this dysfunction presented, okay? So if it's lifelong, it's always been there, right? But if we determine that it's acquired, that should nudge us to want to get more information. Was there a thing that happened, right? That leads us to the issue of the specifier of situational. Is this with everyone? Or is it with specific partners? Again, if that is the case, we want to get information. Is it happening at certain times? Okay, so your assessment will help you to determine when this is happening. The other specifier is going to be generalized, meaning it's happening every time, versus, again, situational. So you're sort of determining, is this situational? Is this every time? And then we're going to have the person help us to determine whether or not this is happening at a mild level, moderate level, or severe. And they're going to be able to assess or really inform you about that to help you determine mild, moderate, or severe. and then you're going to be in the DSM, really delving into the specific categories. But this is a broad overview, helping you understand um, desire, arousal, and those sort of things, and the specifiers generally. So again, I urge you with this one, go into your DSM and read each of these categories specifically so that with the client, you are able to assess when you're looking at the various criteria. Criteria A, if the distress that is presented for the client appears to be mild, moderate, or severe. And that's going to be different for each of the sexual dysfunctions. And they will indicate the criteria, whether it's A, B, C, D. In most instances, it's going to be A, where you have at least one of the following symptoms must be experienced. So we can fully understand how sexual issues can pose a problem in relationships and how that can be a central focus for couples counseling. There are lots of reasons projected for the lack of sexual wellness, coming from jobs to children, schedules, boredom, as well as an imbalance in who initiates. About 20% of marriages are sexless, and a widely used measure, though I don't think there's an absolute one, but a widely used marriage is less than 10 times a year would be considered a sexless marriage. But it could also be defined as extended periods of time without sex. Fatigue is also one of those reasons given for couples presenting for counseling. Additional problems include the pain issue. So if you have a woman who has the pain, then that could create an issue, particularly if it's associated with psychological issues. The same for men in terms of psychological issues impacting arousal. The lack of spontaneity, the lack of variety, the lack of passion or the loss of passion could be reasons to explore in therapy. This is a type of therapy that I would encourage that if you are going to engage in helping couples in this area beyond what is surface, that you really get under somebody who has specialty and training with these particular disorders, because the measurement of some of this is not going to be anything that you can really do in your office, or should be doing in your office. There are specific treatments and remedies and measurements that are used in medical offices to help gauge whether or not this is physiological in nature or psychological. So you definitely want to get under somebody who's in a clinic, a medical office, if you're doing these sort of treatments, so that you have the benefit of teasing apart whether or not it's medical versus psychological. Medical issues, like I mentioned, that could reduce sensitivity include things like diabetes, kidney issues, or even vascular issues. The vascular issues are going to be those blood flow issues that result from some sort of arterial insufficiency. And so if that is happening because the person has vascular issues like blood pressure, that's not just going to show up in the blood pressure, it's going to present in possibly an erectile dysfunction. So the medical issues, remember, we want to rule that out. Heart disease, concern for overexertion, high blood pressure and associated medications could reduce blood pressure and blood flow. Okay, alcohol or alcoholism, which ultimately suppresses the central nervous system and lowers testosterone, could be a source of the issue. So when we assess and there is an alcohol issue present, um, we may want to ask about the impact of the alcohol on testosterone if they know that, or even just interest. There are social and cultural determinants to sexual dysfunction. So there can be learned negative cognitive schemas about sexuality, about sex, about sexual attraction. Um, and so delving into the openness about what is arousing, um, a person's limited skill set, all of that goes into the understanding of sexual disorders. So, again, if you determine that you want to delve into this category of disorders and treatment, certainly make sure that you are teasing out with the help of medical professionals what might be medical issues and that you are engaging in the most up-to-date treatment for that and figuring out what that is.